There are three things that cannot be genetically modified and cannot also be planted with fertilizers. Those are love, friendship, and trust. But we're not going to be talking about love today, and we're not going to be talking about friendship, even though we cherish those. Today, we'll be talking about trust. Welcome, 10,000 Family Study of the University of Minnesota welcomes you to a continuation of our conversations with the communities that we serve. And I want to thank you for finding the time to join us today. And this is our June edition of the Facebook Live event. My name is Victor Ayara. And we're talking about trust. What does trust mean? I have found out that a lot of times people, give different meanings to trust. But I will which says defines trust as assured reliance on the character, ability, strength, or truth or something. And to discuss with us about the very theme of this Facebook Live event, which is It Takes Trust. Of course, is someone whom we have carefully chosen to speak on this topic, not just because of her very rich academic background, but also because of her lived an abundance of experience working with communities. Welcome with me, Dr. Raleigh Dwivedi. Thank you so much, Dr. Raleigh, for joining us. And thank you.
Thank you so much for inviting.
You are welcome. So let me just give you a little bit of background because there is no sheet of paper that can actually contain all of her offices she's held and her experience. But Dr. Raleigh Dwivedi is an assistant professor of family medicine and community health and chief clinical officer at the Community University Healthcare Center at the University of Minnesota. She received her medical training in India and completed residency in family medicine at the University of Minnesota. She is involved with several leadership and quality committees all across Minnesota and serves as director at large within the executive committee of Minnesota Academy of Family Physicians. Currently, she is also leading a disparities in COVID care task force at the University of Minnesota. She is an educator and likes to create new models of teaching culturally competent care deliveries. Her interest in education includes global health and cultural sensitivity in delivering care, as well as improving health disparities, in addition to mentoring medical students and residents. Thank you so much for finding time to join us today, Dr. Dwivedi.
Thank you. Thank you, Victor. Thank you for inviting me, and I'm so glad to be a part of this conversation today.
Thank you so much. And of course, you can always get her credentials and bio on the university website if you happen to want to look into that. But of course, not right now, because right now we are going to have to talk to Dr. Dwivedi. And of course, we need your undivided attention as usual. So tell us about yourself and why you chose this line of work, Dr. Dwivedi. And is it okay I call you Raleigh, right?
That is perfectly fine. Thank you.
Okay.
You already covered a lot about myself in the introduction, but let me tell you a little bit more about myself. So I am originally from India, grew up in India, and then I went to medical school in India, very far from my hometown. And there also, when I was almost about to be done, I chose to practice medicine in rural area for 1 year internship. And that opened up my eyes about the access to care and how important it is to have access to care. And right now we are seeing how important it is access to care itself in India when the COVID is happening and people are dying in the hospitals, in the street. Even in my hometown, there is not a big hospital where my parents live right now. So that was the main aim, that after finishing my residency from here in family medicine at the University of Minnesota, I rotated as a resident at the Community University Healthcare Center, where currently I'm serving as a chief clinical officer, where we focus mainly serving the underserved population. And when I was rotating there, it felt like it was home, and it felt like I was needed there. And it felt like if I will be serving patients who are underrepresented and who are underserved, and I can make a difference in someone's life. And that was the reason that I chose this job, to be working at this clinic who serves a very diverse patient population, who come from 12 different racial and ethnic communities from all over the world, and serve mainly a lot of refugee and immigrants, and a lot of also patients who are underinsured or who don't have any insurance. So if I summarize, my profession and my work currently gives me a purpose, and it brings me home, and it gives me the reason to be here.
Thank you so much. Thank you so much, Rolly. Now, three things actually stood out to me when you were talking. Number one is home. Number two is making a difference. And number three is serving a purpose, which of course are the things that people who are looking to go into any kind of field would like to consider. But before I go to my next question, I want to introduce Shirley Lenner. Shirley is the ASL interpreter. Thank you so much for joining us and making sure that people who are watching or hard of hearing are also included in this broadcast. Thank you, Shirley. Dr. Trivedi, it would be remiss if I don't ask you, especially with the magnitude of COVID cases in India right now, and of course having your people and your parents, maybe relatives and all of that back there. What are you hearing, and how does that make you feel trying to help people totally in a different place than your home when all of this is happening?
COVID is a pandemic, and it is a global phenomena, because virus is virus. It doesn't see who is in front of him. It just affects everyone. And disparities is also a global phenomena. And access to care is also a global phenomena. So issues are the same. We have to put the lenses to see those issues. So it is not different for me what I would have been doing there or what I'm doing here, because it's the same thing that I would have been doing there. Yes, there are more resources, and more resources can happen in a very quick manner. When you are here in the United States, you have to push some doors in order to get the resources. And that's what we have been doing, when we have been providing the COVID care at my center.
Thank you so very much. Tell us a little bit more about the clinic, the Community University Healthcare Center. Tell us about how it started, what is the mission.
So COOC, which goes by Community University Healthcare Center, we have been there for more than 50 years. And it is a federally qualified healthcare center. And if I explain the federally qualified healthcare center, there are centers which get some amount of money from the federal government to support the services and provide the care to the underserved population or people who do not have insurance. But there are very stringent requirement in terms of what you have to do to set up a clinic. And it is, we have a patient governing board. So half of our patient is our patients, and then half of our governing board comes from the community. So they have a governing board. We also have very involved patient advisory board who also helps in moving the care delivery depending upon what is the need in the community. And apart from that, the federally qualified healthcare center also most of them have multiple service lines. So having access to mental health, having access to dental health, other wraparound services like case management or arm services, or we also have on-site interpreter services because we serve patient population in more than 10 languages. And what happens with that is that you have to follow all the recommendations or the requirements, and we get the visit from the federal government every 3 years in order to see if all those requirements are being met or not. And Cook itself is very unique because it is a part of the University of Minnesota, and there are only very few federally qualified healthcare center all across the nations, which are a part of the University of Minnesota. If I remember correctly, I think there are only 8 or 9 centers all across the United States, which are a part of the university. And it makes it unique because our so we have to find a balance or do the things both from the university perspective, but also from the HRSA perspective. We have to meet all the requirements, but the beauty is that it gives an opportunity for our students and the residents and our other faculty members to be a part of the community and learn from the community and create the care delivery model. And a lot of our residents and faculty and the students, when they graduate, they decide to go back into the community and serve the community. So I'm very glad that Cook is a part of the University of Minnesota.
I appreciate it, giving us that background as to what Cook does. Now, since you already have given us the background about Cook, let us talk about your role as a chief medical officer and, of course, teaching at the university. How do you use those roles to, especially when you mentioned making a difference in the community? What is your experience doing that?
So I'm a clinician by heart. And that's what I do every single day, every single minute. How can I make a difference, and how can I listen to my patient better, and what is one extra thing that I can do, what I can provide the patient-centered care. One example that I can give is I developed a curriculum. So our biggest patient population is Somali and East African population, which is about, I want to say 23 to 23%. And one day I was just seeing a patient who had a diabetes and was planning to fast for a month, and was on insulin, and told me the experiences last year when they were having a lot of hypoglycemic or the low blood sugars when they were fasting. And in the exam room, when I was sitting, I thought, well, this has never been taught in the medical school. So this is something that we need to be developing. So then I developed a curriculum in 2014 and involved the community leaders and a lot of religious leaders, faith leaders, partners in developing the curriculum. And that is that was unique and innovative, but also it came from the community. The community guided me to develop something which was needed and which was missing in the medical education. So those are the things that I want to do, and it gives me, because we had a lot of science but there's a missing pieces of art of the medicine, and there was not a lot of how do we be more inclusive of all the cultures? How can we provide the care, a unique treatment plan to a person who is sitting in front of me, and which can be both just not the medicine, but fulfills the physical, mental, social, spiritual, cultural, all the needs. And because if the plan is made together, if it is a shared plan, then there are chances that the plan will be successful. And if I just give the plan, it's not going to be successful. And so that was one example. But since then, we have been doing a lot of um, uh, changes in the care delivery, which is community focused. Another example that I can give is that since the COVID happened, we know that there are disparities are real, and all of a sudden we figured out that a lot of Black and brown bodies were getting affected by COVID, but then the testing was not available to those populations. And then the federally qualified healthcare centers, or the COOC was one of them, who worked with the MDH, and we started doing the mobile testing. We said, if the community is not coming to us, we'll just go to the community and bring the testing to them, because there is lack of access to the testing. And during that process, it's not, we didn't want to do the testing on them. We wanted to do the testing with them. So it needed to be community informed rather than, okay, let's just go and do the bunch of testing. So we did involve a lot of community leaders. We did make a lot of connections in order to make sure that people understand, because a lot of my patients, and I'm speaking for my patients, but I know there are a lot of who can relate to me. There is a lack of trust. There is a lot of historical trauma. There is a fear in the healthcare. There is a power dynamics in the healthcare. And those are the reasons that a lot of people don't seek care. And that's where our community trusted partner come, because they can speak their language and they can help in bridging the gap between me and the community.
Thank you so much, Raleigh. You have really covered a lot that I am sitting down here. I just want you to continue to tell us about what you're doing, because it's a very important work. And I say that because, we're talking about trust, right? And we are talking about meeting people where they are and being able to tailor care for them. And of course, there are other issues of disparities, which of course, it's always been there, okay? Disparities in healthcare delivery. But let's talk about cultural and religious beliefs, because you made a very important point when you talked about somebody who was on insulin, diabetic, and of course, trying to fast. How do you get this message across? Because I can imagine that this is very, very challenging to be able to do all of that work and still consider the cultural and religious beliefs. How do you do that?
So again, as I said, communities are the one who are our educator, because they have been doing the diabetes forever. I might have been doing the medicine just for 15, 20 years. So they are the one, and I'm giving the example of the diabetes. But if you talk about the mental illness, if you talk about other medications, traditional herbal medications, people do a lot of other things. But community, so putting the community onto the driver's seat and getting their knowledge and then tweaking the plan according to that, because I developed the plan for the patient, but the patient helped me in developing the plan by telling what they can do for minimizing those hypoglycemic or low blood sugar, how much to eat, when to eat, how we will be taking the medication, on which day I will not be taking the medication, and me telling them, well, it will be a good idea to maybe not fast. If your diabetes is very uncontrolled, maybe you can give money in a charity rather than fasting. So how do you bring the culture and faith and the science and the medicine together? I think that is the beauty, and that's what I try to bring into the care. The other day, I had another patient who told me about another things that in their culture they do, that for any kind of pain they will beat the egg and they will put the egg on their wherever the pain is. And I don't care. I think it has to be a shared. It's not going to hurt. It is not going to hurt, because a lot of, and so trust and the belief, they go together. I grew up with the family who has done a lot of these things. So if there are things that are not going to be negatively impacting your health, And if you have a strong belief that it is going to help, then how do you combine the modern medicine and the traditional medicine and come up with a plan together where it can be helpful? I mean, I saw a patient together where this young boy had anxiety, and we figured out, okay, rather than using the medicine, let's just start using the Headspace app and start working on your sleep, and let's do some yoga, and let's do some other things. And I prescribed a little bit of medicine on the days when he is not feeling really good, and he can take the help of the medicine. And that was the plan that family wanted. So how do you be incorporating the person's belief and culture into that treatment? And that's what I try to model when I have a student with me or the residents with me, that how can you have this combination of Western medicine and the other medications together and have a third view. I think you were mute, Victor.
I apologize. Well, I was just saying thank you for giving us that profound insight into how you're able to work with the communities that you work for. If you're just joining us and you are listening at home or watching on the go, wherever, this is the 10,000 Family Study Facebook Live event, which happens every other month. And we're talking about trust. The theme of this conversation today is it takes trust. We're talking about COVID and how it affects communities, and of course, the hesitancy, which a lot of people have attributed to lack of trust. So I have as guest Dr. Rolly Dwivedi, who is an expert, to talk to us about this. Rolly, let me ask you, let's talk about COVID, the impact of COVID in the communities you serve, and all of the issues that you have mentioned. What is your experience partnering with these community leaders? I mean, I'm talking about, when I say you, I mean both you, Rolly, and Cook.
Yes, thank you for asking that questions. So I wanted to say, with the COVID, the biggest thing that I said was removing the word hesitancy. A lot of people were using the term hesitancy, and I did a lot of work around switching the terminology to how do I increase the confidence. How do I increase the confidence in the knowledge, skills, attitudes, and belief around COVID testing and vaccination, both in the communities and with the communities and for the providers? Those and in order to do that, we at Cook have done tons of work in terms of developing relationships with the high rises, buildings, and their community leaders. I work very closely with Imam Sheikh, who is a religious leader in the Somali and East African committee. In my disparities task force, I have a representation from Hispanic, Latino, Southeast Asian, and Somali and East African, like several other communities, and it's a combination of researcher and the primary care providers and other community workers. And the work that we started our work with the testing by doing the mobile clinics, or bringing the mobile team to the communities and providing more testing. When it came to the vaccination, again, there people were talking that Black and brown bodies don't want the vaccine, whereas this was not true. Black and brown bodies did want the vaccine. They wanted more information, and they wanted more education around the vaccine. They needed to take some time to make their decision to take the vaccine. So we did a lot of education around all the vaccine. We did several Facebook Live events. Went into the communities and did the education. I hosted an event with Imam Sheikh, who said, well, I will bring several imams. I think there were 16 imams who came from all across the Minnesota, including the rural Minnesota, at Cook, and they received their vaccination, and all imams spoke, and that was displayed at the Somali BBC and the Somali media, and that made a significant difference in our vaccination rate. We also have a partnership with other organizations like WellShare. We also have a partnership with CAPI. We just did 2 or 3 events at Brooklyn Center with the CAPI, which is an immigration center and support the refugee immigrant population. And the biggest barrier for this population was access and the transportation. So we said we will come, we'll do the education, and we'll do the vaccination over there. So and we try to equip our team with the population that we are serving. So when we create the team that is going to go and do the event, it needs to match the need of the population that we are serving. So those are the couple of the examples that we have been doing.
Thank you so much. And definitely, when you were talking, a lot of things jumped out at me. And permit me to say that one of the ones that really stood out was the fact that you already developed a relationship with these communities prior to COVID, which means that you're leveraging on that relationship now that there is a crisis to be able to say, hey, come, let's work with that. Lesson to have before listening or watching, but also things have you noticed when you're working? Because of course everybody says hesitancy, but you said, how do we build confidence? So besides working with the community leaders, what are other things that could, that trust is already existing? And because in this case trust is sacrosanct, it has to be there. So what other lessons have you learned that you're willing to share in your interactions with these communities?
Cook has a history with the communities. So, but especially with the COVID, what we did is the first important thing that we did was, we know that pretty much healthcare shut down. Everyone shifted into the telemedicine. And we at a Cook decided to keep open. We did telemedicine, but we said we will have our clinic open every day for in-person care if someone needs. And the reason that we did is because of so many factors. A lot of our patients needed the interpretation. They needed an interpreter in the office with whom they have the trust. Transportation, so that they just can walk into the clinic. So that was the first thing that we did, that let's keep the clinic open, so whoever wants to come, we will come, they can come, and we will provide them the PPE so that they feel safe to come to the clinic. And we provided the same thing to the providers also, so the providers can feel safe. The second thing we did is, before even educating the community, we needed to educate our providers. So we started having the discussion, what should be the language that we should be using when we are talking with our patient? What kind of information our communities are needing? And what should be the health literacy of those education that we are providing to the communities? And making sure that we are doing the testing or the vaccination with them, not on them. And starting from the beginning, someone might be early responder, someone will be mid responder, someone will be late responder. Our job is to make sure that we give the adequate scientific information about the disease, about the mortality of the disease, what is the risk for this individual person who is sitting in front of us, and how much vaccine is effective, and just being very transparent, so that the person who is sitting in front of you that can make a decision. So that we talked among our provider group, and that's what we have been doing, and that helped a lot. And then apart from that, making sure that we have access not only in person when a person can come in, but a phone line is available. We do have an on-site interpreter. That is a blessing for us. So whoever can needs interpretation, they can call and talk to our interpreters who also come from the communities, and they have a trust already built it, trust with the community. So then they have a direct phone line, and they can call and talk to the people and can help them right away. So those are some of the examples that we did. And the other thing that I wanted to say, that we have a social worker or the care coordinators at our clinic, which were very helpful in the beginning when the COVID hit, because they were calling a lot of our patients to ask their social needs. If someone, especially if someone turns back positive, if you have enough food in your home or not, do you have someone who can bring the medication for you or not, do you have actually a place to sleep or not, can you quarantine or not, and if not, then making sure that we can have access, we can provide access to those things. We do serve a lot of patients who experience homelessness, and care coordinators were really, really phenomenal in helping them, because a lot of people who were experiencing homelessness, they were afraid of getting the testing, that if I get tested, then what's going to happen, because I don't have any place to sleep. So then we developed a relationship with the hotels who were converted into the shelters, that the patient, if they were positive, then we were isolating them into those hotels.
Thank you so much. That's a lot. That's you actually have done a lot of work, and I just want to applaud you. But what are the challenges that you face in trying to work with this? Because if someone is listening to you honestly, they would want to do your job, because you make it sound so easy. But we know that it wouldn't have. There's no way that you would do all of these and not experience some challenges. So what were those, if any, and how did you resolve them?
Yes, there was a lot of challenges in when COVID or not COVID. There are always challenges, but COVID itself, and then also, as people are aware of the murder of Mr. Floyd when it happened, and the civil unrest happened. So we were dealing with three pandemic together: COVID and the civil unrest, and also people were losing their jobs. So economic pandemic. So there were a lot of challenges in terms of even running, like setting up the mobile testing. It took us a lot of time to make a case that the federally qualified healthcare centers are the trusted entity. They are the one who should be going into the community and doing the testing, but it took a while before it could be done. So, but once we got it, then we knew how to do it, and we were able to be successfully doing it. The second challenge is the knowledge gap, in terms of there were so many there are 3 vaccination coming, and there was so much information out there, and managing the social media information with the scientific knowledge was so much challenging. And people had a lot of question, and that caused a lot of mistrust also. And the CDC guidelines also were changing just so quickly, so that also was causing a crack on the trust. So it felt like that we were just running and making sure that people have enough knowledge at the right time. And the third challenge is once person is ready, then we don't have everything in the menu. So we didn't get the Pfizer early in the game. We got the Moderna vaccine in the game, and a lot of people wanted the Pfizer in the beginning. And then at some point, they didn't want the Pfizer, they wanted the Moderna. And then the Johnson's, a lot of people waited for the Johnson & Johnson, and we started the Johnson & Johnson, and the pause happened. So it caused a lot of confusion, and of course, a lot of distrust in the medical care. And managing that part was a lot of challenging. Another biggest challenge for us was that we were into a new EMR just pre-COVID, which is electronic medical record. So we launched our new electronic medical record. We never did the telemedicine. So we stood up our telemedicine in 1 week. And it was impossible to do it, but we did it. And we needed to find a combination between the telemedicine and in-person and the video visit. And a lot of advocacy needed to happen because a lot of our patients have a digital disparities. They don't have a smartphone, they don't have iPad, they only have a flip phone, or they only have a certain amount of minutes in the phone. So it was hard for us. So we needed to do a lot of advocacy around keeping the phone visits alive. So these are the examples for the some of the challenges, and the list goes on.
Thank you so much. I can imagine, of course, all of those things you mentioned could pose a serious challenge to being able to help the communities the way you would. So, with your experience now, what recommendations would you have for communities that are struggling? COVID-19 vaccination continues to be a challenge, with a lot of groups being hesitant, populations very different from the populations that you serve. What are your recommendations to continue increasing vaccination? What do you recommend community leaders to do to increase vaccination in their communities based on your experience?
I would still say it's a combination of the access to the vaccination, easy access. When I say access, it is easy access, being vaccination available at a point of care. So when someone is making a decision, then having the vaccine available. So access to the vaccination, making sure that people have the information about the true scientific data or the numbers, because numbers do matter. And then doing the education at a level where it is easily understandable by the communities. Those are the three things that I will say is the biggest pieces that someone can do in implementing the vaccination. That's what we did, and we have been successful in improving our vaccination rate significantly by doing the combination of mobile vaccination, by creating the care delivery for all three vaccination at our clinic. We started with Moderna, but then we launched the care delivery for Pfizer and also for Johnson. And we all know that all these vaccination have different requirement in terms of how many dosages are in the vials, which need to be ultra cold, which need to be cold, and what temperature requirement. So it takes a lot of resources, but if someone can figure those pieces out and have access and have education available, and then wait for a person to be ready. And giving life examples. I mean, I give the example of my family that I got Pfizer, my boy got Pfizer, my husband got Moderna, my niece got this. So giving the example, and then being transparent and real about your experiences. I know I got ache in my arm, and I did have a mild fever and chills, but I'm alive and I know I'm safe. So giving the real examples, and yes, there are things that can happen, and there is nothing to hide. Yeah, the data is in front of you, and people make decisions for their lives.
Thank you so much, Rolly. So what I'm hearing is transparency. There should be more transparency regarding the experience of getting the vaccine, and of course, what the benefit of the vaccine. Because of course, as you would agree, in recent times there's been a lot of misinformation, and of course, sometimes deliberately misleading people by some groups. So that's not what we're going to talk about today. We're talking about trust. It takes trust. Now, in 10,000 families last week, last Facebook event in April, we talked about historical and current trauma and healing or resilience. We talked some about the impact of the murder of George Floyd and the unrest on Cook and the population it serves. Could you tell us more about the impact you have seen on top of historical trauma? What is Cook's role in promoting healing and resilience?
Thank you for the question. Cook, again, these two pandemics have been really hard on both Cook and for our communities that we serve. But Cook stood strong with the communities in terms of, as I earlier said, in terms of access to the testing. We went to the community, we brought the testing to the community, we went to the high rises, and we trusted our community leaders who were going up and down on the buildings and bringing the community members one by one, watching them, bringing them back home. So that's one thing. But when the unfortunate murder of Mr. Floyd happened, we know that there was pharmacy desert and there was food desert. So we did a drive for the food and the hygiene products at our parking lot. And believe it or not, we did it only for 2 days and 300 people came. And because they knew us, because they trusted us, and they knew that we were not there only for the medical part, we were there with them in this trauma, both physically, mentally, emotionally, and spiritually. And it was so appreciated by the patients. And even with after 2 days of drive, there was a lot of um, stuff left with us. What we did it, our case managers who actually go into the community and serve our patient, they made the packets and they brought stuff into their patient's home. So even though during the COVID it was hard going to someone's house and providing care, but our case managers, they all kept their PPEs and they went into the community and served the community. And that was very well appreciated as well. We know that all the pharmacies around the Lake Street were destroyed and closed, and even the grocery stores were closed. We immediately worked at the clinic, and all the patients who were in that area, we transferred all the medications to the other locations so that they can have access to the medications. So these are a couple of the examples that we were with the community and responded to their needs depending upon whatever the need was.
Thank you so much. You have mentioned a lot of interventions, especially in a crisis like COVID, and of course the unfortunate tensions that arose from the killing of George Floyd. But I'm listening to you, and I see that there's a lot of work that Cook is doing. And by the way, if you're watching this program, you're wondering what Cook is. That is a community university health care center of the University of Minnesota. And of course, my guest, Raleigh, is Dr. Raleigh Dwivedi, is a chief medical officer there. So if you're wondering what are they referring to, Cook is CUHCC. And yes, you have done a lot of, anybody listening would know that the purpose that you mentioned earlier on in our conversation and making a difference, those are very topmost on your mind and, of course, on the mind of Cook. But what other things do you do to foster these relationships, to these partnerships when there is no crisis? How do you partner with the communities? Okay, there's a break in transmission. And these things happen. If you've ever watched a live event or live broadcast, please bear with us. We're talking about the trust that needs to happen in order for COVID vaccine to get to people as they should. So we really appreciate your finding time to join us. And while we're waiting on for the glitch to be rectified by our technical team, we want to also let you know that, as usual, we do have a gift card, okay? Normally, we have a gift card, and in order to be among those who would be lucky enough to be considered, because we're only going to have one winner. So we need you to stay tuned. We need you to contribute, to comment, and of course, like this program, to share it. Let's have a conversation. It's not supposed to be just Victor and Dr. Dwivedi. we want your participation as well. So it takes trust. And if you joined us when I started, trust is not something that just happens. It's not a given. Trust is something that has to be built. Trust is something that people have to build and nurture over time. It's like a good friend, okay? A good friend is not somebody that you just meet today and you'll say, oh, we're all hunky dory. This is my friend. No. Before you call someone a friend, or you have to trust that person and work with that person. And of course, from everything that Dr. Dwivedi has said, there is a lot of trust building activities that have happened prior to COVID-19, which makes it possible for the Community University Health Care Center that my guest is the Chief Medical Officer at, to be able to be there to make a difference and to have a positive impact in that community. So we will be right back, but stay with us. Don't go anywhere. I'm still here. We are going to rectify that technical issue, in a jiffy. But if there's, if you have any comments about building trust, especially in your community, you can send that comment to us. You can ask that question, and we'd be more than glad to get that answer for you. Tell us about what is going on in your community where you are. Are people a little bit hesitant about taking the vaccination? I have not taken it. I have to be honest with you and keep it 100% as usual. But I have scheduled an appointment. And when I do, when next we meet, I'm going to tell you all about it. So send us that comment, send us that question, be part of this conversation. The theme for today's conversation is it takes trust. Is there any way that you can build a relationship that you can say that is a healthy relationship or is a sustainable relationship without trust? Of course not. You can't. So thank you so much for joining us. And of course, you can see the website 10kfs.umn.edu. That is family study of the University of Minnesota. This is a Facebook Live event, and we have been doing this since 2020, and where we bring experts in the medical field to explain and discuss very important issues for the benefit of you, our very distinguished audience members. So boys and girls, stay with us. We're not going anywhere. It's still the 10,000 Family Studies live Facebook Live event. And the 10,000 Family Study is a family health study looking at the impact of environment, lifestyle, and genetics on health and illness in families. And of course, if you go to our YouTube channel or go to our Facebook, you would get a link to our YouTube channel where you can watch all of the other conversations we've had. We've had very, very interesting conversations, and we want to include families from all communities across Minnesota, and we always welcome your feedback and ideas. Your contribution is what makes us, of course, know how we are doing, because the whole idea is that 10,000 Family Study is here to stay, and we are very, very much interested in what you have to say, what your opinions are about what we do and other issues. And of course, it's been quite a while that we've had, I would say that this June actually makes it a year since we started this conversation. Wow, I didn't even realize that. So that's 1 year of conversations and interactions, and of course, discussing different topics. I think that we have a winner of that gift card. Do you want to know? Okay. So the winner of the gift card today is Judy Morneau. I want to believe that I am not totally mispronouncing your name. It's not intentional. So congratulations to you. Congratulations to you. So share your email with us in the Facebook chat, and we would deliver that gift card to you. And so when you see 10KFS at umn.edu, it is nobody trying to scam you. Of course, there are people who are going to try to sneak into your email, promising this and promising that. We're not those kind of people. Okay, we are legit, and you're going to see the email address 10kfs at umn.edu is scrolling right now. That is the email that you should be looking for. If it's any other person telling you to click on, say, ain't gonna do that. Okay, we are going to let you know that you're going to send your gift card to you as the lucky winner. And also, let me take the time to also let you know that the next Facebook Live event is going to be in August. So please keep your ears and eyes open. We are going to come to you with another edition of the Facebook Live event. So, is there anybody who has tuned in that works in for a community health center? If so, please send us your comments. Let us know what your experience is, especially in these unprecedented times. What has your experience been in delivering care to the populations that you serve? Well, I really thank you. Oh, okay, here we are.
Well, my apologies. I just got the notice that the Comcast shut down, so everything stopped working at my end.
Really, totally understandable. It is called technology, and it does happen. I'm going to tell you, maybe not right now because we've lost a lot of time, but I can tell you that in my former life, when I used to be a broadcaster, a lot of things happened, but I'm not going to go into details. Maybe talk about it in the next episode, but I'll tell you when we go offline. Okay, but if you, the viewer, wants to know, you all right. So that glitch for making the time to come back. I just want to ask you a few more questions that we should be ready to go. Are there other things you want the audience members to know about Cook, and of course, and the population that you serve?
Yes, definitely. Thank you. First of all, again, my apology. But yes, Cook also, I think I mentioned in the beginning, but Cook has a whole person care approach, and we try our best to have the care delivery or services which can be holistic and have physical, mental, social, and spiritual needs. So we have not only the medical services, but we also have mental health services, which include psychiatry and therapy. We also have a big dental clinic on site. And I said in the beginning, we have wraparound services in terms of case management and arms. And we also have sexual assault and domestic violence advocate on site, and also prenatal midwifery services. So pretty much we provide services for everyone, and we can do a lot in that clinic. Those are the things that I wanted to mention.
Without a doubt, you can do it. Where can people, I'm sorry about that. A lot of things have been happening today, but we are soldiering on, okay? Where can people who are watching this program and probably did not decide to get vaccinated, but listening to you speak and everything they decide to, where can they get that information to know where to go to get vaccinated, I mean?
Well, you can come to Cook. You can call Cook and definitely can come to Cook. That's the first thing that I would recommend, and we will welcome you. But there are other 17 federally qualified healthcare center in Minnesota, and 10 of them are here in Minneapolis and St. Paul. So people can just Google federally qualified healthcare center in Minnesota. They can go there. Minnesota's Department of Health Vaccine Connector is the best option because it will help you in finding the locations where they will be closer to your home. If Governor was just announced there's a pop-up vaccine clinic happening at the airport. But if you go to the MDH the connector, there are several vaccine pop-up event happening all across Minnesota during the weekdays and also around the weekend. So there's a lot of vaccination available. There is also, if someone is in urgent need of getting the vaccine, there is a website, Vaccine Hunters. People can go onto that website. If there is an urgent need and they cannot get in onto anywhere, they can go and find vaccines over there as well.
Thank you so much. And I promise you we don't have too many questions to ask at this time because I have a very important question which I like to save the best for last. Okay, we're going to get there. But now, from your vantage point, what do you think is the importance of 10,000 families study for the population that you serve? What do you hope might come out of it over time? And from your work in partnership with the communities at Cook, what lessons do you see for the 10,000 family study?
That's a great question. Thank you for asking this question. I think I have said it several times during this conversation. A lot of my patients have significant social determinants of health, which examples could be living situation or living conditions, lack of access to fresh fruits and vegetables, or poor transportation, poor sanitation, lack of access to care, lack of access to medication, poor ventilation. You just name it. There's a long list that keeps going. And we know that the time has proven again and again that disparities are real. But my hope is that with the result of these studies, we can have the transformation of the structural barriers and then have access to education and the food and health. So system-wide and the structural changes that can be taken or the policy changes that can be taken with the help of the result of this study.
All right. Now let me ask you the big question because I did promise that I'm going to ask a very important question. You work for the community, you work for Cook, you teach. What do you do for fun when you're not functioning in all of these wonderful roles? What do you do?
I love cooking. I just love cooking and I love doing yoga. I work a lot, but when I come home at night, I cook every day. Um, and the reason I do it because when we talk about the food, we all come from earth and food come from earth. So it grounds me and it connects me. And a lot of food items are colors and colors bring joy to your life. And then when your work, when you're cooking, then you are touching the food. So food brings not just the color, but it also gives a lot of you feel different type of textures. And at the end, if there is a creation of a dish, you feel like there is a final product that you share with your family and friends, and it brings the joy to me. So um, I also, and again, we will save it maybe for future, but I do incorporate a lot of food because for me, food is a medicine. So I do incorporate food and yoga both when I'm providing care to my patients.
Well, the way you describe the food, actually, Rolly, you make me hungry, and I'm gonna look for something to eat when I get up from here because definitely, it's I am a foodie, and I am not ashamed of admitting it publicly. So whatever you're gonna do with that information, that's okay. But thank you so much. Do you have any recommendation for someone who wants to volunteer? We're gonna just do that quickly. Volunteer with Cook. I mean, to join in the fantastic work that you're doing.
Yes, definitely. We can. Anyone can call the Cook Clinic, um, and uh, and then leave the message that they are interested for the volunteering. And we have a lot of restriction due to COVID right now from the volunteering perspective. We do have, again, as I mentioned, being a part of the FQHC and being a part of the university, there are significant requirement even with the volunteering, which comes with a lot of trainings. But anyone is interested, call the clinic, leave a message that you're interested, and our chief operating officer probably will reach out to them.
Thank you very much, Dr. Raleigh Dwivedi. Before you go, what would be the three words if you were to speak to someone who is watching this broadcast? Three words that you would leave them with that encompass all of your great work and all of your passions. What are those three words?
Peace, trust, and healing.
Thank you so much. We've been speaking with the Chief Medical Officer of the Community University Healthcare Center of the University of Minnesota, Dr. Dwivedi Raleigh. My name is Victor, and I really appreciate you taking the time to join us. Do not forget that we would be back in August. Keep a date with us. In the meantime, go to our Facebook page and go to our YouTube channel and watch all of those old videos. And thank you.